All right, so welcome. Thank you guys so much for coming today for our session. We really wish we could have been in person, but we're still glad for Zoom so we can connect and hopefully have a recording available for everyone to watch later. But we're really excited to kick off the first of our 4-part series. It's a collaboration we have between the UC Davis Mind Institute, as well as our School of Medicine's newest forming SIG, that's the Developing Mind SIG. And so some of our goals just over the long term are we're hoping to have discussions together and basically really learn from some panels how we can explore different areas that encompass understanding, treating, and working with populations who live with disabilities. And hopefully we can just further improve our branch of healthcare, just starting with understanding the minds and bodies of others. So with that, I'd like to introduce Kathy from the Mind Institute, who will introduce our wonderful speakers today.
Thanks, Rupa. We're really excited to be partners with you and that we've helped develop a new SIG for the medical school. And today we decided for our first session that we would look at the topic of sharing the news, conversations with families about disabilities. And we are really, really fortunate to have 2 wonderful speakers that are going to partner on the topic to inform us about that whole experience and what it looks like from a medical perspective and from a family perspective. And I'm really honored to introduce the 2 people that will be talking because I have great respect for both of them. You will be hearing today from Dr. Scott Akins, who is a developmental and behavioral pediatrician. He is the Chief of Developmental Pediatrics at UC Davis Mind Institute. And joining him will be Heather Scott. She is a mom of 6 children, including Gabby, who is 19 and has Down syndrome. She is a founding member of the Down Syndrome Information Alliance, and she works as an infant educator at Sacramento County Office of Education Infant Development Program. So I will turn it over to Scott and Heather.
Right, I'll start first. I'll share my screen, Amber, okay? Okay. Okay, is that sharing okay?
Yes.
Okay, great. So we're going to go through 2 parts of the lecture. I'll talk initially about just some general information about disclosures and sharing the news, about difficult conversations with families or sharing diagnoses. And then Heather will give us a family member perspective. We'd be great if we could have discussion as we go. We'll have a number of slides where we can answer any questions you might have. And ideally, this will be just an opportunity to have open discussions about some of these issues and some of the challenges and difficulties that we all face when hearing difficult news or when giving difficult news to people, families and people we care about. All right, so first of all, just a quick overview of Down syndrome, because we are going to talk mostly about Down syndrome today. I love this slide from the CDC. It just shows the wide variety of different kinds of folks that can have Down syndrome. From the young businessman to just the cutest kid you could ever see up in the corner there. And it also really makes me think about how much this condition has changed over the last 20 years. When I was first in practice, we weren't so great at managing many of the complications, and we had different long-term outcomes. Health outcomes and developmental outcomes. We didn't have clinical practice guidelines yet that ensured that we looked for things like sleep apnea in every young child, thyroid disease, growth deficiency, celiac disease. There's a number of things that we manage so well now. And of course, we didn't have early intervention services. And we just see really different outcomes than we saw 30 years ago. And I think that's something that's really important to keep in mind with any group of individuals you're treating when you're thinking about long-term information about prognosis that you might be sharing with families. But it's a great looking crowd, right? There. All right. So just briefly, I'll start by overviewing medical disclosure. So one of the terms you use, certainly the term we use in genetics, is a disclosure. So physicians in all fields, no matter what you decide you're going to do over the next few years, are frequently required to disclose diagnoses to their patients and families. Commonly, we were talking about this a little bit ago, you discuss new diagnoses of common treatable conditions. asthma, diabetes, cataracts, and of course you do it all day. But this is new information to families, and even something as common to you in your clinic is eczema or asthma, or having a discussion about placing ear tubes in a 1.5-year-old. That's not a routine conversation for families. There are a lot of concerns and fears that come with some of that information. And it's just, really critical for all of us to continue to try to partner with families and engage in collaborative decision making, and make sure that we share information in a way that's received and can and where people feel safe asking all the questions they have to ask when you share information with them. Specialists, many of you might be thinking about being a specialist, and if you're a specialist, of course, one of the things that I don't think I understood, I'd been a general pediatrician for 6 years, and then I knew I wanted to do fellowship, but when I went, I just don't think I understood the difference in every day talking about difficult diagnoses and sharing difficult information with families almost every day. And so, of course, there's common things that we all discuss, from cancer to lupus, genetic disorders, serious heart disease. Many specialists have those conversations every day. So that's tough. You have to learn to take care of yourself. You have to learn to seek support. You have to learn to do it well. That job's going to be really rewarding for you. Does that make sense? I mean, you're going to see these folks that you're having these conversations with, depending on where you live. You might run into them, at your kids' baseball games, or at a school event, or just in the grocery store. And when those interactions and the interactions you have in clinic are consistently positive, you will feel, like a successful physician that really has an important role in people's lives, someone that they really count on and that they trust. I've had colleagues where that does this thing, and this kind of challenge in other areas around the human communication don't go well over time, and it's a much harder job if that's the case. So empathy, patience, confidence, often when you're exhausted, when you have divided attention, when a family's priority doesn't match up with yours, right? Where you're thinking like, we got to get going, like I'm thinking about intubating someone in 5 minutes, and people are asking questions that, are important, but that won't be relevant in the next 7, 10, 15 minutes. They're a tomorrow question in my head. And learning how to have those conversations, set priorities, still partner with people, leave somebody behind to finish out that conversation, come back. Those things are all really critical that you learn over time. I think emotionally, we've learned so much more about secondary injury and providers over time, and just about some of the traumatic experiences we have as physicians in practice, or healthcare providers in practice. And I just want to recognize briefly and talk about some of this if you want today, that sometimes it's a lot harder if it's, of course, someone or someone that reminds you of someone you grew up with, or that you're close to, or your brother or your brother's child, or whatever it might be. Sometimes it's just harder for whatever reason, in the moment, or on your way home, or when you wake up in the middle of the night, or what have you. And I think it's important for all of you to learn to be able to talk to people about that, to find some people you trust to talk with about those kinds of issues, and to just recognize that everybody feels this, that's what it is. That's what we do for a living. And that, you'll get through those feelings if you learn to seek support. It's also really tough with someone that frustrates you, where you're trying to give information and they're just not in a place where they can accept information, or even begin to have a conversation. That can be really tough, especially if you need to get to a point where some decisions have to be made. And when that happens, we need to bring in a team or have someone else help manage conversations. But I just want to, first of all, just recognize that those are all things that happen. The next thing is as medical students, we're learning that you have real power as an information broker. I remember as a medical student, seeing my friends wherever, on the soccer field or out at night or whatever, and I did not think of them as powerful information brokers, and they should not have thought of me that way either. But you're starting to make this transition where you have a more professional role, and patients see you as someone who what you say really matters. The words really have an impact, and we'll talk about that. And one of the things we know from the Down syndrome research And is that things that we say in these moments have an impact that lasts for 15, 20, 30 years, and that patients have nearly complete recall of these conversations 20 years down the road. So, and I'm not saying this to build up all the pressure around these conversations, but just to kind of frame this as a period where we want to be mindful. We want to set aside some time, and we really want to just recognize the importance of these conversations to your patients. I talked a little bit about this already, but just, taking care of yourself. And as I said, learning to share the news in a collaborative and supportive manner is really important. Learning to seek support from your friends and to debrief after particularly challenging disclosures. So what I mean by that is, my wife's a healthcare provider too, who does infectious disease and HIV care. And when I was doing palliative care for children before, I could always talk to her about it, and she completely understood it. If I tried to talk to my dad about it, he would listen to me, but I remember early on, being frustrated sometimes that he didn't get it, and he just wasn't living on the same planet. Those weren't his challenges. So you have to find some people where you can seek support and be able to debrief after challenging disclosures. The same is true if you have a team. So if you've had a particularly challenging case, especially if it's someone you've been managing for a while, and then the diagnosis changes and people have a lot of guilt and frustration because they thought they should have picked it up earlier, or it's just a particularly challenging diagnosis, something like a neurodegenerative disorder in children where they're going to progressively get worse and have and die from that condition in the end. It's really important to debrief your whole teams, just like you do after codes. And then so a few other things. Just these are relationships. I really can't stress this enough. The relationships, some of the toughest disclosures I ever did, the hardest one I ever did, I had a text from that family this morning letting me know they were moving and moving to Hawaii and wanted to tell me. And and that's years later. So some of these relationships will really enrich your life and your practice and help you be the physician you want to be. Okay. So general principles, we'll review these a couple times, but general principles about disclosures. You want to, the timing matters for both the family and physicians. If it's a mother that just had a C-section and you're going to go in and have this conversation, you should give her a little time to recover and make sure that she's recovered enough to have this conversation. Spouse should be there, and you got to set aside time. Many disclosures take 15 to 30 minutes. And it's really, you got to find a way to carve out that time. And that might mean that you go in a couple hours later, you have a brief conversation, bring the team back, and that's okay. Sometimes if you're like I just talked about, that neurodegenerative disorder kind of a diagnosis, that's going to take a long time. And not every team member needs to be there that whole time. You can rotate in and out, but the core members should stay for that whole time. Role should be established. This thing around spiritual support, if a family, some families will request a chaplain or other spiritual support, and certainly you want to meet that request if possible. And then, think through who needs to be there. This idea that a lot of times you haven't met a family yet, but if it's someone that you do know, it's good to think carefully about how they receive information. Would they want spiritual support there? Which family members would be critical to have present, location. Heather's going to talk about this a lot more, but you don't want to be interrupted a lot. You certainly want a private location. Pretty much all units, have a specified room. If you're a NICU or ICU, a PICU, there's specified rooms available. You want both parents together, if at all possible. It's not very fair to tell one parent news that then they then have to share, which those parents can't take all the information on when you're giving it initially. So it's really important to have them together if at all possible. Some things you've probably been learning in your doctoring classes, clear, concise language, frequent pauses, avoid acronyms and medical jargon, really important to do that, and be honest and direct. You certainly don't want to take away hope, and you don't want to provide a lot of extraneous negative information, talk about outcomes related to a disease that we aren't going to see forever. For example, we don't talk about, early risk of Alzheimer's or dementia in children with Down syndrome when we're sharing the news. That's something we can talk about years later. It just doesn't have any bearing on what we're talking about right now, and it's too much information. Oops, sorry. Go back. And then pause and wait. I prefer this to asking if people have questions. If you can just be silent for a minute and wait, people might need to just say something that isn't a question. They might need to make a statement, and you can ask questions if you don't get anywhere. A lot of families will say things even when you're giving the most, difficult information, like, I don't want to take more of your time, doctor. Doctor, I know you must go. I always tell people, I'm not doing anything more important than this today. Like, we will just be here as long as we need to. There's nothing else I'm doing that matters more than this. And then lastly, just understand that people might react strongly and ask you questions you might not be able to answer. People might ask about anything from God to how can you tell people this kind of thing, and you just sit quietly. You'll learn to manage all that, but that's those are things that happen. Okay. So what do you do? The next thing that's so important is you just want to have follow-up conversations. So people can only take on so much information at one time, 10 or 15 minutes of clear, concise information. So any other questions for me? Can I leave you all alone for a little bit, and we'll set a time for me to come back later this afternoon. In the interim, it'd be great if you guys can write down questions that you might have. I'm going to have someone bring in some written information, and then we'll be back. Come back. You tell people you're going to come back, come back. People don't sometimes. That's a very solemn responsibility. And then, written information about the condition and let people process this. Some of the other things to think about that happen a lot is, at the end of or maybe when you go back a lot of times and follow up after people have processed information a lot, people think that mothers think I have to call my mom and tell her, or my sister, or in some difficult relationships they have, or that's a really tough thing to do. And you can help people kind of formulate a plan around who could make those calls. I always offer to be there or to help make calls. For family members, it almost never takes more than a couple minutes. Those calls always go well, or almost always go well. Generally speaking, one of the things I tell parents is, after I've listened for a while, I'll say, your mom, if someone says, I'm so worried my mom's how she's going to take this, generally, you can say your mom might surprise you. Let's give her a chance. I'll be there to support you when we make that conversation. When we have that conversation, what can you tell me about what you think her greatest fears are going to be, and how can I help with that? Would it be okay if I said these things? And then we just go, and it works out. I ask sometimes who's hardest to tell. If somebody is kind of so worried about everybody they're going to tell, and then who do you think is going to be most supportive for you? Who do you need to call? Who's your friend that you think can help you? And sometimes that's really important to have that be the first call. Social workers can do this, psychologists can be available, the chaplain's really great at doing this providing this kind of help too. But sometimes it is the physician. And so I just wanted to make sure you know that you really can be helpful in all those things, and it can help get somebody started right away with framing this information more positively, if that makes sense. And then the last thing I'd say about this first part is you should expect discordant coping. If you talk to two parents, one person might be stuck in denial right away. Like, Doc, I think he's going to be all right. Doc, I really respect you. I know you know a heck of a lot more about this than I do, but I don't see it. I think he's going to be okay. And the other person might be immediately trying to understand it all and going into next steps. What do we do next? What kinds of therapies? Do we need to have a surgery? And when those two people are sitting in the room together, if that's a tough dynamic for them to sort out after. And you can help with some of that too. And I usually talk directly about discordant coping and just in the stages of grieving. And that's a whole other lecture that you'll learn later. But it's pretty typical for patients to not feel exactly the same way when you have two parents about this kind of news when you're having a conversation after. So some of the protocols, I talked about this a little bit already. There are a bunch of different protocols for delivering news. Advanced preparation is this ABCDE protocol. It's nice to have mnemonics, but So just get ready, know your patient. If you don't know the condition very well, look up what you can, call an expert, make sure that you at least know what is likely to happen in the next few hours, couple of days, and be able to answer some questions about long-term and prognosis. And you don't have to answer all of those right away, but be as prepared as you can. This thing I was talking about earlier, the ensuring adequate time and privacy, seating for everyone, eye contact, sit close enough, touch is okay if it's appropriate. That's building a therapeutic environment. So that's your B. And we talked about communicating, so avoiding jargon, using plain language, allowing for silence, and moving at the patient's pace. That just means, even if you really want to get out of the room, sit and learn to get comfortable in those situations, so people have some time to think about everything you're saying. And sometimes people are stuck on something you just would have never anticipated that they ask about. It might be they had a sibling that died 30 years ago from something that they're thinking about, and you're disclosing something that's a non-fatal condition, but that's just where they're stuck, and you're not going to know if you don't sit and wait. And then you can put that fear aside for somebody and help them have a better understanding of what we're talking about today, and what their child needs. People are encouraged and validate emotions, actively listen, explore feelings, and express empathy. So this is an emotional process. And the part above about dealing with patient family reactions, I don't really know what that D means. If you do everything else well, you're helping deal with all that. And it is okay to correct misinformation. And so that's just, you need to ask questions and actively listen to find out what people might be thinking that is erroneous or information they hear from elsewhere. So that's a protocol. So I just thought it'd be helpful to really briefly review Down syndrome and to set up a little bit. I'm going to tell you about a case where I'm going to show you all these things that, how you should deliver the news, and in a case where it didn't go to plan for me, just to emphasize that, it's just so important to do the best you can, and to also emphasize that many times when we're giving a diagnosis, it's dynamic and you don't have all the information, but the families know there's something going on, so it's important to share information. So just a brief review about Down syndrome. So prevalence, I'm going to skip to the bottom, is about 1 in 700 births, so it's still pretty common. It has changed a little. It used to be about 1 in 660. It had been as high as 1 in 720 in different parts of the world. But the overall prevalence has remained pretty stable over the years. Among mothers aged 37 or older, the vast majority receive the diagnosis antenatally, so after screening, including ultrasound, that above 35 with advanced maternal age, we do more intensive screening. Among younger mothers, antenatal diagnosis is less common. These numbers are a couple years old. They're not the 2002 numbers. They're newer than that. But that antenatal diagnosis, even in younger patients, is becoming more and more common. One of the, a classic board question for many years was the majority of children diagnosed with Down syndrome are diagnosed, prenatally or antenatally, and the answer was, antenatally or postnatally. The answer was postnatally, because many more children with Down syndrome were born to younger parents. I guess that's that. This just shows increasing risk over time with maternal age on one side, and then risk of detection of Down syndrome. And you can see how it does increase with age. And then just briefly to review characteristic features, these aren't consistent in all children, but upslanting palpebral fissures, epicanthal folds, and a flat nasal bridge are common. A small upturned nose is common. And then short nape at the back of the neck is what we look for on prenatal ultrasound. Sometimes ears are real small. Brush-filled spots are little tiny white dots around the iris, and can be very helpful if you're trying to make a clinical diagnosis on a child that isn't very, whose facial phenotype isn't really consistent with Down syndrome, but you're trying to make the diagnosis clinically before you get a karyotype back. some other things. This is called a sandal gap, this little spot here. Some kids have short, broad hands. You can have a transverse palmar crease, or your fifth finger can be incurved. But as you can see, these are all pretty subtle findings. There's nothing here that's that clear. And then why does this matter? Because if you're making the diagnosis in the newborn period, which is what we're going to talk about for the next 20 minutes or so, there's a number of potentially urgent issues, including congenital heart disease, GI issues that need to be managed pretty quickly. So just to, Heather will talk more about this, but you want to be positive when you're, anytime you're sharing the news about a diagnosis. And then I was just going to briefly tell you about the first time that I was working in a nursery, maybe a year after residency, and there was a baby that was born who had an oxygen requirement, who was a term baby, who had respiratory distress. His blood pressure was a little low, and he had a murmur. And one of the nurses thought he had some of those facial characteristics that we just saw. And I came up and did a clinical exam, and he certainly did have most of those characteristics, including brush-filled spots. So I was pretty sure that he had Down syndrome. His mother had just had a cesarean section and so was unable to come to the nursery. I was in a special care nursery, and this baby had an oxygen requirement, so I couldn't carry him back to the room to be with his mother. We had moved him into a special care nursery because he had an oxygen requirement, and his mother couldn't come to us. I had just done a lecture to our residents a couple weeks before about this and knew I needed both parents together. And Dad was there wanting to know what was going on, and that this child, and so we had a frank discussion about it. He was actually someone that I knew, and we agreed that I would come in and talk to his wife in a couple minutes. And he immediately ran and told his wife, and, like you'd expect, because it was too much information. And then I went in a couple, 5 or 10 minutes, and let them know that I was concerned about Down syndrome and why, that we needed to transfer the baby for concerns about congenital heart disease and possible intervention, including surgery, and then stayed with them. And so a couple of the rules that I shared with you about how to do this were violated in that situation. And it went just fine. And of course, I interacted with them very often, and we went back and shared information, written information. A few minutes later, I called the grandmother, some of the other things that we talked about. So that I bring up because, many times you just need to do your best. So discussion, and I want to make sure we have ample time for Heather still. Any questions or thoughts about that so far? Okay, Heather.
Alrighty. Wow, I can already, in full disclosure, like my anxiety, my sadness, just listening to Scott review some of these guidelines is pretty strong. So I apologize right off the bat if I get emotional. 19 years ago, I had my daughter, Gabby, who has Down syndrome. I had a very long labor, something like, 39 hours. It was very traumatic. There was her umbilical cord ruptured, so there was a lot of drama. The room filled up with a lot of people all at once. And they had her on a table, and there was a lot of damage to myself. So the doctor was working on me for quite a while when Gabby's father was out in the hallway, and the neonatologist told him in the hallway, "I think your daughter has Down syndrome. I'm going to go deliver twins, and we'll come back and we'll tell your wife." And then he left him standing there alone. And I don't even know like how much time had passed, but my husband at the time had called our uncle, and he joined us. He's a family doctor in the area. And all of a sudden, I finally got to hold her, and there was the neonatologist, her dad, and my uncle. And I just remember them saying, your daughter has Down syndrome. We're really, really sorry. And I kept thinking, well, how do you know? like, I know you haven't done any tests or anything, so how do you know? And he goes, oh, I can tell just by looking at her. And I remember uttering the words, but she's so beautiful. And so how do you really know? And my uncle grabbed my hand and he said, I wouldn't let them tell you if we weren't for sure. There's just some features that we see, but we're pretty positive that she has Down syndrome. And then the doctor left, and that was our entire conversation. Even after she was born, we didn't know if we were having a boy or a girl. And I remember it took about 20 minutes for somebody to even tell me if she was a girl or not. I had to ask. And understandably, there was, they were worried about her medically. But I just had this vision of, congratulations, it's a girl. And there was none of that. We were in the recovery room for about an hour and a half. And one of the nurses went to take her to the nursery. And I said, well, where are you going? Where are you taking her? And they said, oh, well, we need to go give her a bottle. So we're going to take her to the nursery. And I said, oh, I have every intention of breastfeeding. I said, I didn't even buy bottles at home. We're going to nurse. And the nurse, I swear she almost chuckled. And she said, oh, honey, babies with Down syndrome don't breastfeed. And she tried to walk out of the room with her. And I really remember thinking, holy cow, she is only, I don't know, hours old, and I'm already being told of things that she'll never do because she has Down syndrome. And it was like pivotal to me. I really think that luckily I am the type of person where I tend to buck the system and show people differently. I remember calling my godmother, who rushed to the hospital. She was the only person I knew who had a child with a disability. And I mean, she fought with the nurses to come in that room because it was past visiting hours. She did not care. And she grabbed me by the shoulders and she said, you can do this. You had her for a reason. You can do this. And I think that was a pivotal moment for me. We met 6 weeks later. So that was our only conversation the day she was born. The next day at the hospital, I remember a geneticist coming in, and I don't even remember him like telling me his name or what he was doing. He walked over to the little, bassinet that she was laying in, and he started almost like picking her over. He was looking at her ears and looking at her feet and looking at her hands. And I said, who are you and what are you doing? And so he said, I'm a geneticist, I'm looking for traits of Down syndrome. And I said, so tell me then, what kind of traits are you looking for? What things do you see? And that information sharing, I think, is so pivotal. I'm to just not be afraid to come in and say the truth. I think you can balance that truth sharing with kindness and compassion. 6 weeks later, we had an appointment with our geneticist. So those were the only two conversations in the hospital about Down syndrome. I was given a book that had super outdated information. We went home, 5 days later, I think. We had a follow-up appointment in 6 weeks with the geneticist, who said, well, I walked in and I was feeling really good. We had 6 great weeks at home. Things were going well. And I said, so I think I've got a pretty good grasp on things. Like, I've done a lot of research and we've done a lot of reading. And just for the sake of it, my daughter is super healthy. She had no heart issues, no GI issues. I mean, we struggled with feeding for a little bit, but super healthy, super strong. And so I said, so I think I've got a pretty good grasp on this. Like, she's going to be fine. She's just going to learn probably at a slower rate. And we might have to switch things up and teach her things a little bit differently, or our life's gonna look a little bit different, but I think we're pretty good. And he goes, okay, but she's gonna stop learning at like 3rd grade. No more learning for her. And I was like, but how do you really, really know that? And he didn't. And so fast forward to where we are at age 19. She graduated last year from high school with her diploma and a 3.5 GPA. She is a freshman at American River College and taking 2 classes online virtually, Spanish and photography. She is the light of our lives and has taught us so much. And I am so grateful for this experience. But I can attest to the research that has been done about the day that diagnosis was given to me and how heart-wrenching it was for me. And I have so much guilt for feeling so sad because of the way it was presented. And I really believe that had a few things just been different, it wouldn't have felt so devastating to me in the moment. And I wouldn't have this all-encompassing guilt that I have, you know, almost 20 years later, because I look at her and I think, how could I have ever been sad just to know who you were? And so in 2004, I founded the Down Syndrome Information Alliance, and we're a local nonprofit. And one of our big priorities is that parent-to-parent support. A firm believer that as a physician, you can't know everything about Down syndrome, you can't know everything about every resource, but we have people that can be there to support a new family. And I talk to every new family that calls our organization myself, and I can tell you that in all honesty, like stories like this are still happening. Maybe not as much or as deep, if you will, but parents are still getting this news in a really devastating way. And I just want to be honest and say I can't, like, the list of do's and don'ts is pretty you know, long, and it can feel overwhelming. Like, how can I have this perfect scenario to tell a new family that their child has Down syndrome? I think the number one thing that I would say is don't hide from it. I talked to every mom who said, well, I knew right away that something was wrong, but not a word was spoken. So whether it's just the feeling, the energy in the room or whatnot, families know that something is wrong with their child and they don't want to be shielded from it. They really want to have that information addressed as soon as they can. I don't know if we can go to the next slide. Thank you. Thank you. So just, you know, we have a handout on our website, and it's for medical professionals, and it's just a really nice cheat sheet of kind of the ABCs of delivering a diagnosis. Scott, you know, touched on many of these topics, but who should be there? Definitely, I would think, you know, in all honesty, trying to have the mother and the father, you know, the parents together is the most important. Maybe having a few other colleagues so that there's, you know, some information sharing, and it's not shared on just one person to share all this information with a family. Next slide, please. Sorry, thanks. Again, when should you share the diagnosis? Firm believer in as soon as possible. Like I said, parents already know that something is different about their child, whether they can see it in them. I know many moms who said, you know, I kept asking the doctor, do you think my child has Down syndrome? And they would say no, but the mom saw, you know, characteristics. So whether or not the parents see it physically or whether or not they can just tell that there is something different, they really want that information as soon as possible. Again, I think about that issue of privacy. When the doctor told my daughter's father he was standing out in the hallway and our 2 best friends were sitting on a bench waiting, and my friend always says, like, I can't even believe he said that information in a hallway for anybody to hear and just left him standing there. So definitely that private area is best. Asking, you know, I love the idea of calling somebody for you. I really remember thinking, how do I have to tell everybody? Like, do I send an email, or who do I call, or how do I tell everybody she has Down syndrome? So some of that can be a little overwhelming. So just being aware of those things that are happening.
hey, Heather, and sometimes that I just made me think, sometimes when you call that one critical support person, they tell you, I'll send the email to everybody. You don't have to do, I mean, you know that, you know, so many of those things,
Absolutely.
when you start bringing in support, good things happen, right?
Yeah, for sure, for sure. And I think too, like Scott mentioned, we don't need to go down the long laundry list of things that could happen to your child with Down syndrome or things that they could be affected by. Let's cover the basics, the things that we need to look at the first 24 hours. You know, hard information, like those are the things that as a doctor, you guys are going to be looking at. Some basics just about Down syndrome, how is it caused? I know many families who are told by whatever doctor that they're dealing with, whether it's an OBGYN and it's a prenatal diagnosis or it's at birth, many doctors tend to tell parents, be careful because this is likely going to end in divorce for your family, because there is that notion that families who have children with special needs get divorced at a higher rate. There's actually fascinating research around Down syndrome and it's actually at a much lower rate, but just kind of not putting those ideas out there, you know, right away. Those aren't things that need to be addressed in the first 24 hours. And yeah, and knowing that there's like resources out there, like the Down Syndrome Information Alliance, we have, you know, fantastic trained parent mentors who are, you know, trained to be a great first point of contact for a family. Okay, next slide. Everybody, I mean, every mom wants to hear the words congratulations. And so we work really hard at whether it's a prenatal diagnosis. And I have a mom who just said, oh, I had an ultrasound and we found out the baby has Down syndrome. And I always say congratulations on your pregnancy. And I can tell in the parent's response back, like how much that means. They're so much more relaxed, so much open to hearing what I just said, excuse me, and the understanding that having a baby, like physically is ridiculous. Emotionally, it's off the charts. And so when we address it from that positive momentum of congratulations, like you just had this miracle happen, it makes all the difference in the world. Parents don't want to hear I'm sorry because they'll quickly realize that there's nothing to be sorry about. So yeah, parents expressed the most satisfaction when they were congratulated, told with their partner present, and then had sufficient time for the opportunity to talk. I love the idea of sitting in silence, seeing if the family has any questions, and then revisiting it the next, you know, your next day or a phone call later or whatever that is. And then delivering a message of hope. I think, you know, maybe a family will ask you questions or doctors may tend to project, but I just think that that's really unfair. The fact of the matter is it's a newborn and we have no idea what this person is capable of. And we would never, you know, tell a family what their life is going to look like with a typically developing baby. And so I think that that's a huge disservice when we do it with a family who has a child with a disability. And I think that truly it can be a pivotal point for a family in how they're able to cope with this news and basically pick themselves up by their bootstraps and move forward. For many families who get this news and they're told, you know, your child will never do A, B, and C. Well, guess what? Those kids do, because as a parent, well, I was just told by a medical doctor who knows way more than me that they won't, so we're not even going to try. And I think that is the key difference for the success of a lot of our, you know, adults with disabilities as we move forward. Just having the ability to try to do things, or, you know, even be pushed and expected to. So when we tell someone your child's never going to learn past a 3rd grade level, like I said, luckily for me, I'm the type of person who's like, oh, okay, I'll show you. That's in my nature. And luckily for me, it worked out good in this instance. But for some families, that can be all they need to hear to not kind of push forward and really demand the best life for their child.
And in that moment, you have such vulnerability to postpartum depression and just all the physical change. It's just the last thing anybody needs. And it's so easy to just say, however you want to say it, but well, it's up to her. Let's see what she can show us. She looks pretty spunky to me right now. I'm betting on her. Whatever you want to say, it does cost us nothing to do that.
Right. And it's not true, right? We have no idea. We have no idea what the future holds. And there's so many resources and so much support in so many accommodations and modifications when it comes to education. Like really anything is possible. So let's just see what this little one can do. But let's also take them home and love them too, because that's key at this point. Scott, I think this is one of your slides, right? Maybe, I don't know. There we go. Oh, okay, so there's my daughter.
Here's the money slide.
Her high school graduation picture. She was super proud. Obviously with COVID and not having a graduation, she was a little ticked off, but super, super proud of her.
All right. I can start. I just keep thinking about in your story, even after the things had gone wrong when the geneticist came, if he could have just sat and picked her up and laid her on the bed next to you and said, here are some things I'm concerned about. Started saying, congratulations, look how beautiful she is. Here are some things I was concerned about. Do you see those? Does that make sense? That just could have been a reframe and a chance to get going in the right direction a lot sooner.
And I think like laying that foundation for educating me as a parent on Down syndrome and what are some things, and including me in it instead of making me feel like I wasn't a part of it. And really, we know that there's so much more success when there's that partnership among providers and parents. And so if that would have happened from the beginning, it would have been key.
Other thoughts from anybody?
And I just want to open it up too. I'm super open to any questions that you guys may have. I'm a big believer that when we know more, we do better. So if there's, maybe a question in the back of your mind that you're like, oh, I could never ask that out loud. Like this is a really safe place to ask some questions if it'll help you guys.
I just had a question / thought. I guess, when we're trying to plan ahead, if you're going to share a diagnosis with a family member, we usually try to, say like, okay, we want both parents present. But do you think it also kind of gives the parents a clue when we stress out, let's say, in trying to schedule an appointment? Like, I think you'd want to bring someone, maybe a companion or family member, someone supportive with you to the appointment if you might need it. Like, do you feel like that also kind of gives them the hint that there's something, like something's going to happen?
Yeah, I would think so. I don't know how that would have felt, honestly, if, that was the case. So I can only imagine like how hard it is to balance saying, okay, we need both parents there versus addressing it right on. All I know is, trying to do your best, but that seems really hard. I want to be super sensitive that some of the things that we're suggesting, I know seem impossible in the moment.
Yeah, that's why I wanted to do that little case where, having just given a lecture, 2 weeks before about exactly what to do, and then you couldn't do it in a minute, it doesn't mean that you can't go back. And normally I would have done a couple more slides after about just basically what I described. You go back and sit with both people and both parents and stay and just kind of, you have time to get it right later if you can't do it. Certainly people are aware, and people will often ask if you're the one making the call. We'll say, what happened? Is it something terrible? And you will learn over time to say, this is a conversation we should have in person. It would be really good if your spouse is there. And you can say, this is, if it's true, this is nothing life-threatening. I don't want you to worry about that. But and don't tell people, I'll see you in 6 weeks. That's I'll see you tomorrow or the next day. Or nowadays you could probably do a Zoom call. But it was, it was hard to get work scheduled, get people to get off work and be there at 2 o'clock in the afternoon if you're doing genetic disclosures. But it is hard. That logistically it can be hard sometimes. Rupa, it can. Other questions? Okay. Heather, do you want to add anything else, or should I go on to that next section?
No, I'm good. I'm good.
Okay.
Thank you.
Okay. So just, there's a group out of Hopkins that's done great work on Down syndrome forever. A guy named George Capone has been the senior clinician and researcher in that group for 40 years or more. And they started looking at much of what we just talked about, maybe 10, 15 years ago. And they've got some, there's this article in Pediatrics that I'm referring to on the bottom, did regular U.S. Preventive Health Service evidence-based review of all the articles that have been done, both qualitative and quantitative studies about how people take the news related to Down syndrome. And these are the level A recommendations that came out of it. And we're almost out of time, so I won't go through all these, but they're in the slide set, and it's everything we've said, basically. And then there were some level C recommendations, just less evidence for them, but definitely a good idea. Follow-up appointments as well, first conversation related to issues that occur in the first year, and infant present, and saying positive things about the infant and what you expect. And if you can, positive things, I'll frequently, I hope if I was in the room with Heather when you asked about how she was going to do, that I would have said, well, she's got you, I think you're going to be all right. And there's so many opportunities to say things like that to families. So if the baby's there, there's the conclusions. We've already said all of this. And, we talked about these things told with their partner present. So.
The UC Davis Mind Institute was founded in 1998 with a promise to reduce and prevent the disabilities that can be associated with autism and other neurodevelopmental conditions. Every day, our clinicians and researchers make progress on that promise. Our groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other conditions associated with disability are helping affected individuals achieve their fullest potential. Please visit our website or our social media platforms to find out more about current studies, upcoming events, and how you can help make a difference.